I'm Dr. Fred Southwick, professor of medicine and author of Infectious Diseases, a clinical short course. And today I want to review with you the key facts about community-acquired pneumonia, CAP. My goal is to provide you with the information you will require to understand and manage this common and potentially life-threatening infection. Our module on community-acquired pneumonia will consist of 4 short instructional videos, and each video will be approximately 10 minutes in duration. Epidemiology and pathogenesis, etiologies and clinical manifestations, diagnosis, and 4 treatment and prevention. Diagnostic and treatment recommendations are based on the Infectious Disease Society of America guidelines. Before we discuss the epidemiology and pathogenesis of pneumonia, a few words of warning. This is a serious infectious disease that requires your deep understanding so that you can act quickly. You won't have time to read over your notes. You must develop long-term memories that will allow you to manage these patients in a timely manner, because a delay in antibiotic treatment increases the risk of a fatal outcome. Community-acquired pneumonia is one of the most frequent infections you will encounter. Worldwide, it is the leading infectious cause of morbidity and mortality, and the third leading cause of death. In the U.S., there are on average 740,000 hospitalizations per year and 41,000 deaths. The older you get, the more likely you are to develop pneumonia. The overall annual incidence is 1.5 to 2.4 per thousand, going up to 6.3 per thousand for ages 65 to 79, and 16 per thousand, or over 1 per 100 for 80 years or older. I wanted to emphasize the high incidence among the elderly over 65 make pneumonia the leading cause for their hospitalization and the leading cause of their death. How is pneumonia contracted? The major route is by inhalation of droplets. In the case of COVID-19 and influenza, and to a lesser extent for rhinovirus, by aerosol particles that are less than 5 microns in diameter and can remain in the air for up to 3 hours. Closed, poorly ventilated spaces are high-risk environments for contracting this infection. Strep pneumonia, Haemophilus influenza, and Moraxella can spread by droplets and then colonize the upper airway and result in pneumonia due to microaspiration, often at night. These organisms are often carried by children, resulting in intra-family spread. Less commonly, respiratory viruses can enter the host via fomites, that is, surface particles, spread from the hands to the eyes by rubbing. There was considered debate about how SARS-CoV-2 spread that has led to a more careful analysis of how all these pathogens cause pneumonia. This table summarizes our current knowledge. As you can see, droplets are the major route for all pathogens. Aerosol is seen in most of the viral causes, and fomites, that is, contracting it by touching surfaces, is less common, being documented in 3 of the viruses and none of the bacteria. Another key point is that these infections tend to be seasonal, being attracted most commonly in winter when people are crowded together in closed spaces and when the air dries out our mucous membranes, interfering with our host defense. In order to survive, humans possess a number of mechanisms to prevent bacteria and viruses from entering the lung parenchyma. First are the nasal turbinates that contain mucus and hairs that trap particles. Second, and one of the most important defense mechanisms, is the epiglottis. This tissue flap lies over the trachea, preventing food and fluid intended to enter the esophagus from reaching the trachea. If there is any dysfunction of the epiglottis, we all have accidentally inhaled some water or food at one time or another, we have a powerful cough reflex that expels this unwanted foreign material. In addition to our cough, our trachea and bronchi are lined with mucin-secreting epithelial cells. Mucin is deposited on the surface of these cells, where it can trap bacteria and viruses. These epithelial cells also have beating cilia on their surface. The cilia act as a conveyor belt and move the sticky mucus upward toward the pharynx. If bacteria manage to bypass all of these protective mechanisms and reach the alveoli, macrophages and neutrophils combined with immunoglobulins and complement can ingest and kill these invading pathogens. Given these robust defenses, why is pneumonia so common? When acquiring a history, it is important to keep in mind specific risk factors that increase the likelihood of aspirating mouth flora. Pneumonia occurs most frequently during the winter because of the higher incidence of viral upper respiratory infections at that time of the year. These infections result in increased nasal exudate production that drains into the posterior nasopharyngeal space, particularly at night. The exudate may bypass the epiglottis, carrying nasopharyngeal bacteria into the tracheobronchial tree. The major reason that the elderly have such a high incidence of pneumonia is because with aging comes strokes and other neurological impairments that can lead to swallowing and epiglottic dysfunction, increasing the risk of aspirating food, liquids, and nasopharyngeal exudate. Another major cause of epiglottis dysfunction is heavy alcohol ingestion, anesthesia, particularly during dental procedures, and overuse of sedatives. Dysfunction of the bronchial epithelial cells can also increase the risk of pneumonia. Smoking damages the cilia and results in thickened mucus that cannot be effectively transported by the cilia. Influenza virus also damages bronchial epithelial cells and their microcilii. There are also genetic diseases that interfere with clearance. Cartagener's syndrome is associated with a genetic defect in cilia motion. Cystic fibrosis patients have a defect in salt transport that makes their mucin excessively viscous, blocking cilia transport. Finally, patients who are immunocompromised, this includes elderly patients and other patients with chronic diseases, they have impaired production of immunoglobulins and reduced cell-mediated immunity. This sketch note summarizes all of the factors that predispose to pneumonia: viral URI, influenza, smoking, alcohol overuse, other sedating agents, stroke, and chronic underlying diseases, particularly chronic obstructive pulmonary disease or COPD. Finally, let's look in a little more detail about what happens at the alveolar level when bacteria or viruses are able to invade these air sacs, which are responsible for the delivery of oxygen to our arterioles. In the case of bacteria, they stimulate an innate immune response. Alveolar macrophage TLR signals a marked rise in cytokines and chemoattractants that attract polymorphonuclear cells or neutrophils. As these cells ingest and try to kill the bacteria, superoxide, proteolytic enzymes, and small antibacterial peptides are released into the alveolar space. When viruses enter the alveoli, the alveolar macrophages release interferons that stimulate antiviral activity by epithelial cells and macrophages. Additional cytokines and chemokines attract T cells and natural killer NK cells that target and kill virally infected host cells. Both innate and cell-mediated immune responses damage the alveolar walls and lead to the accumulation of inflammatory fluid that blocks the delivery of oxygen to the arterioles, resulting in right to left shunt and a drop in PaO2. In summary, CAP is common and deadly. 1 per 100 age 80 or older contract this infection annually. The infection is spread predominantly by droplets and aerosol. The lung has many protective mechanisms to prevent bacteria from reaching the alveoli, the epiglottis being the most important. We reviewed the many risk factors for community-acquired pneumonia, and finally demonstrated how innate and cell-mediated immune responses to the invading pathogens results in alveolar damage and hypoxia.